Okay, so for this video, we are going to just focus on tracheostomy care. If you need to review anything about airway patency, obstructions, respiratory assessment, and signs and symptoms of distress, please go back and review the tracheostomy suctioning video. In the first portion of that, I go over that information. For the trach care procedure, you'll need sterile gloves if you're going to use your own. Like I said before, I like to use 7.5s because that's what fits best. So I have those with me. You'll need a pair of clean gloves. You'll need, again, sterile water or saline, a stethoscope, your pulse oximeter, and your trach care kit. And in the kit, it's going to look a little different in the hospitals probably, but you have the pocket nurse trach care kit. And in there, you'll have a sterile drape, a pair of sterile gloves, the trach ties, the drain sponge, which goes underneath of the trach faceplate, a couple of sterile swabs for cleaning, the sterile brush for cleaning, and you should have 4 of the 4x4 gauze. And then this one has 3 different compartments that we will use throughout the procedure. Depending on what type of product your facility uses, you might have saline or sterile water and also a hydrogen peroxide for cleaning. So use whatever product they're using and whatever their policy is. Okay, let me put my stuff back in here. The first portion of the procedure will be sterile, and then I will let you know that I'm technically going to be clean procedure throughout the rest of it. But you'll see that I try to remain sterile throughout the remainder of the procedure. But I will declare when that is ready at that point. Okay. Your oxygen, again, with this procedure, we're going to hyperoxygenate the patient. And we're going to be assessing, just like we did with our suctioning, to see how they are doing throughout the procedure. And again, if they have a lot of secretions, we might want a face mask, goggles, or a face shield for the patient. Okay, so we have our order, and typical order is usually tracheostomy care either every 8 hours or every 12 hours. It is not necessarily respiratory therapy's job to do. In fact, a lot of reimbursement is when the nurse documents that the care was completed and done. Obviously, if they have any kind of copious secretions, we might need to change things more frequently to prevent them from getting skin breakdown issues. Okay. It's a good thing to have suction available at the bedside. Again, we did 80 to 120 when we were suctioning our patient before. And of course, before we do trach care, we would assess to see if the patient needs suctioning anyway, and do the suction prior to the cleaning. So we have our order. We're on a 12-hour shift, just gonna do routine care. We did suction a little bit ago. We have our supplies all ready to go. I'm gonna bring a little bag with me too. I am going into the room, identifying who I am. So I'll let Mary Jean know that I'm going to be doing your dressing care and trach care for your tracheostomy. And I get my identifiers with my name and date of birth against the wristband. She may or may not be able to vocalize that. And explaining the procedure again, shouldn't cause any discomfort, just so that they know and so that you know when we're messing around a little bit with moving the faceplate and stuff, it could cause them to cough a little bit. And of course, when we're doing our assessment while we're going through, if we notice any change, then we know that we could put the trach collar back on the patient so that they can reoxygenate. So we're going to assess first to see if she needs suctioning. So just like we did prior to suctioning before, I'm going to auscultate. I do in the 5 spots anterior. And she sounds pretty clear, so we're happy with that. I'm putting her pulse ox on her. We'll leave this on through the entire procedure. I am just going to make sure that it's okay to put this bag here as my trash bag. We've increased our O2 up to 15 liters per minute, 100%, so I'm going to let her hyperoxygenate while I'm getting my field ready to go. Like I was saying before, if we have that disposable inner cannula, the one that kind of just clips on there, I would just use clean gloves, get rid of the old one, wash my hands, put new gloves on, and plop the new one in there. And that would be the process for that, or whatever your policy is for your facility. For the non-disposable cannula, which is going to be for this process, this one has a locking mechanism. So if you look, there's little dots right there, and we want those to lock up and measure up. That means that it's locked. If it's not, then this is going to come out freely. So we always want to make sure that it locks in place. But this is a non-disposable one. So this is what we're going to be cleaning. Let's see. We've got her hyperoxygenating. Again, like I said, you can have suction at the bedside just in case you need to. I've just got it there. I've kept it on the whole time. I don't need it right now. We are going to get our supplies ready. I'm always going to want open away from me. I'm going to come in here. I'm going to lay my drape. Shiny side goes down. If you want to put these gloves on, you can. I'm not going to use them, so I'm going to get rid of them. And then it's up to you. You can do 2 ways for loading your field. If you want, you can come in at an angle and dump everything on, if you're good at dumping. The other option, if you are not very good at dumping, I'm going to loosen this so that I'm ready to go. If you are not confident in your ability to dump that onto your field, you can take one gloved hand with a sterile glove, and you can gently pick your stuff up with that hand and place your stuff on your field. Remember, we have a 1-inch border, okay? Then I could take this with the non-sterile hand, the clean gloved hand, and pour into each container. And just like with your trach suctioning, depending on your facility, maybe it's a one and done, or maybe it's you have to use it within 24 hours. So we make sure it's not expired, and if it's not open, making sure there's no issues with the integrity. All right, so then I'm going to come in and I'm going to put my second glove on. Okay, fix my gloves. Now I'm going to rearrange this so that I can just kind of seamlessly go right down the way. So my trach tie is fine over here. I'm going to put my bristle brush, then I'm going to use my swabs, and I'm going to get my 4 gauze ready, and then my drain sponge, which will come up underneath of the trach. All right, so she's been hyperoxygenating. She looks in good shape. I'm going to use my non-dominant hand. I'm going to move this trach collar to blow by. And again, the whole time I'm assessing to make sure there's no issues going on with her. I'm going to use this to unlock my inner cannula. I'm going to dunk this to get it wet. I'm going to take my brush and I'm going to go from the bottom to the top, and see, I'm standing away from my field so that I'm not splashing it everywhere. And then I'm cleaning to make sure the outside is clean as well. Then I'm going to go in and rinse it in a different compartment. So this is contaminated. This is now going to be considered contaminated. And I'm going to let it air dry. And then I'm going to gently place this back in and lock it. And at this point, technically, I can use clean technique for the rest of the procedure. I'm going to get rid of this dirty drain sponge. But just to show you that you can still maintain sterility, I'm going to go through. I'm going to use my final one to moisten my cotton swab. I'm going to gently tilt this faceplate and I'm going to clean underneath. And then I'm going to do the other side, tilt this up and clean underneath. And just so you're aware, when patients have these copious secretions, those little tiny cotton swabs are probably not going to do. You're going to probably have to use more cleaning power to get in there. But it is good to help for loosening up the gunk. And then I'm going to dunk my first gauze in there, and I'm going to come through and clean my faceplate, which is all gunked up. Come through and clean my other side of my faceplate that is all gunked up. And then we're going to dry. And then dry the other side. Again, watching my patient to make sure that they are not having any signs of distress. If they were, I would put the trach collar right back on to let them hyperoxygenate. And then we usually use Velcro type fasteners, but in your totes, you'll still have ties, so that's what we're going to have you use. So I pulled the tie through and I squared it up at the top. I'm going to gently tilt the patient's head forward so that I can wrap around. Now, super important, when you are changing your trach ties or the tube holding device, do not take the old one off until you have the new one on and secured. Because what happens is if you take off the old tie or securement device and the patient coughs, and they will cough because we're manipulating, we're cutting this old tie off now. Maybe. It's tangled up behind his head. So we cut the old tie off. This is the new one. If I don't have anything to secure this and they give a nice forceful cough, this whole entire tracheostomy tube can come out. And then they don't have a patent airway necessarily. So an example, there's 2 examples actually that I usually give my students. One of them is my coworker has a coworker that she had worked with who is a very seasoned nurse working in the neonatal intensive care unit. And she, being a seasoned nurse, was going in to change the tracheostomy and do trach care, and took the ties off, and the baby forcefully coughed, and they couldn't get another airway in the patient. So the baby ended up dying because of it, even though they tried everything to get a new airway in. And then the other example is, shortly after I taught about trach care, this is probably about 3 years ago now, a couple of my students came in the following week and they were like, it's true, it happens. If they cough, their trach can come out if they don't have the ties secured. They were in clinicals and their patient had a newer tracheostomy. The patient was in the bathroom trying to change the trach ties himself and took the old ties, or the old securement device, off and didn't have the new one on, coughed, and they said he came into the hallway turning blue and his trach was halfway hanging out, and they had to hurry up, and the students didn't, but a couple of the nurses went and shoved the trach back in so that he had an airway. But because it was new, he very well could have coughed that out and then could have had the same demise happen. So that's why we don't take these trach ties or securement devices off until we have the fresh one on and it's in place. And we want to make sure that we have about 1 or 2 fingers here on our securement device or our ties, and then it's not pressing hardly up against the carotids, because we don't want to cut off blood flow. And then for the drain sponge, personally, I make little bunny ears and I tuck gently underneath one at a time. And gently pull those through. And then I can put my oxygen back on my patient and let her recover. Something else to keep in mind is that if for some reason you are using these old ties and you need to go and cut them off, the old ties with the scissors, please make sure you do not cut off the balloon pilot or the pilot balloon port, because if they have that inflated, there's no way to deflate. So be mindful that this we're leaving alone. We're not, no scissors to it, okay? So we've let her reoxygenate for a moment or so, get her breath. Make sure her color looks good. Make sure her pulse ox looks good. She's at 96%. She's returning to a regular breathing pattern. She's not showing any signs of shortness of breath. I'm going to go ahead and turn this back down to whatever the order is. So we said in our suction that she was at 30%. So we put her at 30%. And I'm going to take another listen just to make sure. And of course, looking at that pulse ox. And her lungs still sound the same as they did earlier. They're fairly clear. Her breathing pattern looks good. Her color looks good. She's at 95% with her ordered O2. She's in a comfortable position. Any other issues that need to be addressed, whether it be pain, positioning, address that. Make sure that she's in a comfortable position. Make sure we get the bed to the lowest position. Head of the bed probably is going to remain at 30 degrees with a lot of our trach patients. And making sure she's got her call light nearby and everything. And I think that is it for that. You would document what everything looked like, the dressing, whether there was copious secretions, maybe they were tan colored, small amount of secretions on the dressing. And then also, just so you know, this gets really gunked up in the trach collar fairly often. So Usually a washcloth or wipes would be good for cleaning that. You don't need to be sterile when you're cleaning that. The tubing a lot of times is changed out like every 3 days, or whatever the facility's policy is. So those are just some things to be aware of. And that is it for trach care.